So, compensation plans. Where's the money? Most providers, I would say, get a stacked compensation plan. And what I mean by that is you have lots of different pay elements together to come up with a compensation plan. So you put these together to align with your organizational goals, to align with your financial goals, to align with your clinical goals. A good example of this would be most organizations still get most of their revenue fee for service. I don't know what the exact mix is, but it's probably still at 80% of the revenue.
Probably.
At least
I
there.
think Medicare and Medicaid's largely still
fee for service. There's some value base to it, but it's like 8% at risk or something like that. It's not large dollars. So if you're thinking about most of my money is fee for service, I'm paying physicians a lot of money. Is there a way I can align their compensation to be fee for service? Work RVUs aligns a little bit, doesn't account for payer mix, but you see a lot of people that private equity does a lot of collections-based models, so it aligns a little bit more. So what are some of the types of pay elements? These are very popular right now. I would say recruitment incentives is probably one of the number one areas of interest in compensation plan design. So student loan repayment, starting bonuses, relocation bonuses, fellowship stipends. So this is one where if I'm a resident, I still have another year and a half. I think the most I've seen is 3 years, where every month a health system will pay you $1,500 before you even start employing. So you get 36 months of another $1,500. It's just really an advancement. The student loan repayment, I think I actually just got a call from a colleague, and they had for a radiologist, they were doing a starting bonus of $150,000. So it's pretty meaningful. Quite a bit of money is going into the incentives competing over. But yeah.
What clawback do y'all recommend for signing bonuses?
So definitely have them. I would say the most common is probably 3 years. And it's probably going to be amortized either monthly or annual. Say if you work 1 year, we take 1/3 off. I have seen some that are 5 years with 100% commitment that if you don't work here the entire 5 years. I would also advocate too for FTE requirements. So you don't want to pay somebody, say, $100,000 starting bonus for 1.0 services. 2 years in the arrangement, they want to maybe go to a part-time, spend more time with their family. Well, you've already spent $50,000 extra on this. So having some work requirements is an area I think, especially with a lot more folks working, I guess, consolidated hours, or that's a pretty common area. Also see a lot of different work schedules. So family medicine, there's a health system in Southern Ohio. They just went through this 3 36-hour shifts for a family medicine team. So they were open Sundays. So they had a team that worked Sunday, Monday, Tuesday, and then another team. And it was with the whole front office too. So the front office scheduling, everybody worked the same shifts. And they were open 12 hours a day, 3 days. And then basically I did two things. One is the providers were happy because they got to spend 4 days with their family. The other is it created more access in the community. And then the third is it actually got a higher return on your fixed assets. So if you have a expensive building and it's only open for 40 hours a week, now it's open for 70 hours, you're getting a higher return on that investment there. Base pay, draws, guarantees. These are pretty common pay elements for providers. The Guarantees are probably used for new hires that have experience in the marketplace. Maybe you're hiring the neurologist down the road. They're going to bring their patients, maybe take a little bit of time. Hey, we're going to guarantee you X amount of dollars, and then you go to an eat what you treat model. Speaking of language, I wouldn't call it eat what you kill. It is healthcare. Not appropriate. Draws and advances. So if you're doing bonuses, so thinking about the incentive alignment, it's not very, people don't get incentivized if you only pay them once a year. So, hey, I'm going to see more patients next month. I'll make it up. I'll do it next time. So the most effective from like a economic standpoint is to actually pay people in advances and then have them pay you back if they don't meet it. So like Wall Street does this sometimes, that if you work at a big PE firm, they actually might bonus you $1 million on day one, on January 1st. If you don't meet your metrics, you have to write them a check back at the end of the year. But I don't think that's good for liquidity. No one wants to be in the repo business. Like, you don't want to have to go to a tow truck and like tow somebody's Mercedes down the road. Like, not very good. Yes.
Sorry, question about draws. Because the system that I was a part of had like significant like quality bonuses as a part of their pay structure and like lower base comp, but like most of their providers did not meet the quality incentives and they did not do draws. So like, do you always recommend draws for systems?
I would, I think it depends on how often you're paying providers. And some folks might do like door openers. If you're talking about quality, I would think about what is the minimum work standards of that provider. So if I'm going to say like closing out notes would be a good one. If I don't get paid, I'm not going to pay you. I know that sounds harsh, and it's your responsibility to close out notes. If you don't do that, I'm not going to pay you a production bonus. Quality, I think it depends. I've seen it structured if you're like a leader of the medical practice, we kind of expect you to have high quality scores. So you might see it structured as a door opener. So in order to get your production pay, you have to meet your quality pay. And you see that too with shared savings agreements. So does anyone know what a shared savings or gain sharing arrangements are? So it's basically if you pool the cost savings together, you share it with the physicians in the different organizations. Some of the regulatory requirements for that is that you can't impact the quality of care, that is, or limit it either. You can't limit care to Medicare or Medicaid beneficiaries. You also can't impact the quality of care, and you can't pay for volume. So a lot of times what you do is you look at quality pay for the last, or quality metrics for the last 3 years, and say, hey, in order to get your shared savings, you have to maintain this level of quality. I know you were talking about the draws. A lot of folks too, in quality pay is a little bit unique, is that you don't get your quality pay from payers for like a year and a half. So it's in arrears. So if you're getting a quality bonus, it actually, for like 25, I won't get my quality bonus until 26, right? Until the middle of 26. So it's a pretty big lag on timing of payments as well. Production pay, you're probably going to see work RVUs as the most common, followed by collections and panel size, sometimes some case visits. The big trend now too is going from just 100% individual to group models. So this is an area I'd look at it, trying to come up with an example. So radiation oncology is a good area. The work RVUs for certain cases doesn't really match the time commitment that's needed to do it or the volume of business. So if you're doing radiation oncology, you're probably doing most of the time prostate cancer. Very lucrative. But you're going to have some cases that come in that have to do with head and neck or different areas of the body. Those cases sometimes take more time than what you can do with prostate. So if you're on a work RVU model, you might say, hey, we have 4 physicians in this area. We want a couple of them focused on prostate, and we have a couple others focused on different areas of the practice. But to make the incentives equal, we go to a group-based model where maybe you take 20% of all work RVUs and you share it equally, and then you do an individual bonus payout on it. And then coverage, same thing. I would look at minimum work standards, like how do you define a 1.0 FTE? What is the number of shifts or hours you need to work? You could have a draw for those as well that, hey, we're going to pay you 10 shifts a month in advance. Quality too. So this is kind of, we talked about the gate openers and then the administrative piece. Only comments about that would be, is it hourly? Do you have to do a time tracking? Is it stipend? And then buying down time is another concept. So if you're a medical director and you work 20 hours a month, you probably don't need to buy down your clinical time. But if I'm working maybe 100 hours a month, maybe I should. So maybe I should be at 0.75 there. And it's not consistent. Every organization has a different area.